are back with us to take us through the vaccination improvement programme. Committee members will be aware this is a really crucial piece of work, I think, for the health board. I won't steal anything out of the papers, but I think there's quite a few work streams here which we just need to pull together, and I'll hand over. I don't know if it's a bit of a double act, Pam, yourself and Tim, to take us through this.
Well, probably if I kick off.
Yeah. You kick off, Tim. Thank you very much.
Okay, so this paper was brought. Vaccination had been discussed at various committees, including clinical governance, finance and performance, and the board, but tends to have been discussed a little bit less at this committee, and I think partly for that reason that the paper was brought, as well as there being a lot of activity at the moment and potential change with vaccination. The background, as people will probably be aware, is that we needed to move through COVID from general practice delivery of vaccinations as part of the new GP contract and the vaccination transformation programme to board delivery, and that was initially done for some adult vaccinations, particularly COVID and flu, and in the end, in March 2023, the rest of the vaccinations followed. It has been a difficult time for vaccination generally. We have had some opposition to, and there's long-standing opposition to vaccination moving from general practice to the board, not everywhere within Highland, but in many places. There have also been difficulties with performance. In general, adult delivery of vaccination has been reasonable. Children's vaccination, it took a bit of time to get the statistics in, has not been so good. There's a secular trend nationally for it to go down. It's also been going down a bit more a bit more than the national trend locally. So various different work streams were put into action, and which I think started last year, just under a year ago, with Scottish Government increasing Highland HSCP to level 2 of the performance framework. The other two work streams were one around getting Public Health Scotland in as a critical friend for peer review, and secondly, about looking for a different model of delivery, which was initially locality model, but more recently in-depth discussion of a potential mixed model with general practice delivery and board delivery where appropriate. Sadly, a child death in Caithness then occurred, and that has speeded things up. I think certainly speeded up the peer review, and also got a lot more concentration on many of the issues. In terms of management, before we get to management action, I've included as an example a table of vaccination update for children's vaccinations within the Health and Social Care Partnership on page 64. And that shows there's been some improvement in vaccination over the last few months, but I think the improvements have been more in the promptness of the vaccination and a little bit less, certainly for MMR, in terms of the overall coverage. So, while there is some movement and some improvement, there's still a very long way to go. The Public Health Scotland peer review took place, and I've included as an appendix to report the full peer review report, and that's available. It's been available for several weeks now, publicly on the NHS Highland website. That has given rise to a range of actions, and they're being taken forward through a vaccination implementation group, which Pam chairs. Just to run through quickly the governance. So like other services, the responsibility for the delivery of almost all vaccination services, bar things like maternity, but almost all vaccination services are the responsibility of the health and social care partnerships to deliver, but there is an oversight function for the board as a whole, as a public health service. So that's why I've got a role and Pam's got a role, but the delivery role, like other services, is for the Health and Social Care Partnership. The management actions are principally now being taken forward through the Vaccination Improvement Group, which, as I said, Pam chairs. And one of the principal actions for that is the development of an options appraisal around options for the delivery of future vaccination and what will be best in each locality. And a lot of work has been done by Claire, who's on the call, and by Jill Mitchell, who is away at the moment, on working with colleagues to look at what options are the most sensible to be considered and recommended for whether they be approved by the SGPC committee that's already been mentioned earlier on in the meeting. There's also just come out, and members who live in Highland may see this, a survey of vaccinations and what public think of vaccinations. I already received mine by text via my practice, so many people may get that, and so we're trying to get a rounded picture of vaccination. There's still a lot of challenges and a lot of issues. Our performance is nowhere near what it should be. We should have uptake which is higher than the national average, but we're still lower. So that's why I put limited assurance still within the paper. But there are some good signs of recovery, but it will be something that will take a long time to develop. So I'll stop there. It may be that Pam, Claire, or others may wish to comment, or certainly be happy to take questions.
Thank you, Tim. Pam, Claire, there you go, Pam.
Thank you. So just in terms of the operational parts of this, we have stood up a vaccination improvement group, which I chair, which initially met weekly in order to get in place all our planned improvements. So we started off with 28 improvements. We've made significant progress on them, across the 7 areas of governance and leadership, access, people's experience of vaccines, the workforce aspects and planning that we need to consider, significant digital and data issues in terms of bringing this forward, and of course the finance. And of course it does fit with our earlier discussions around the CTAC, the community care and treatment services, and around our negotiations and engagement with our local Highland local medical committee in terms of that options appraisal and how we take forward some of our aspirations to deliver going forward. So we met again this morning. A lot of our actions are in green, and one of the key things that we were outlining this morning is where the actions are in green, what's the actual evidence, where is the standard operating procedure, what does the new policy look like, what does the achievement and the digital output look like, what's our workforce plan look like, so the next meeting we can consider them in more detail, and that Tim as executive lead jointly with myself can move to signing off that some of the actions have been completed, so that we can provide that assurance to EDG, but also provide that to the Scottish Government in terms of moving towards demonstrating improvement, and for them to evaluate that support that they're giving us in terms of our level 2 performance escalation. And I'll stop there. Thank you.
Thank you very much, Pam. I've got quite a few people who have already got their hands in the air. But maybe if I just kick off, and it's probably not with a question, but is maybe to set a bit of context, and I'm sure some of this will actually come out in the questions and the comments that colleagues are about to make, and maybe just to explain the role of this committee in the process, because I think, as Tim has highlighted there, this is probably a slightly complex one in terms of there's a delivery function which falls within the remit of the Health and Social Care Partnership, and ergo falls within the governance remit of this committee's, and then there's performance aspects, and there's actually clinical delivery aspects which fall within, if for assurance purposes, fall within the sphere of the clinical governance committee, and hence the need for probably multiple papers, but papers probably covering different aspects of the service. And I think what this committee has been concerned about probably since the springtime, March, I think it was, Pam, when we first started talking about this, was the potential stroke probability of a change in the delivery model, and our ability to be delivering via an alternative means by the commencement of the autumn stroke winter vaccine programme, particularly as it relates to adults, is what we were talking about, the flu programme and the COVID programme. And we knew there was going to be an options appraisal undertaken there, and I think that it's due for completion any time now. But I think we were also aware of there was delivery challenges in terms of how far people have been asked to travel, making appointments, etc., etc., some of which were related, we know, to the national appointment system. So I think, and I suppose the only way to do it is actually to say, I think what we were hoping for today was actually to have a discussion about just exactly as you just outlined there, Pam, evidence and demonstration that we are a significant way down that improvement place, and what are the timelines for the actions that we're still to complete that would allow us to be in that better place going into the winter. And we don't have that today. I think I'm going to be just to say that we don't have that today. So I'm not sure what confidence. If I just speak from an Orkney perspective, I've already got my appointment for the winter and flu vaccine programme in Orkney, and I'm sure people are now beginning to get their letters in Highland, because I can't imagine that Orkney's working in a different timeline to the rest of the country. So that's really just the context of where we are. So I think it's I'm probably just setting the context of us. As chair of the committee, I'm concerned that we don't have anything in front of us that actually says this is exactly where we are, this is the work we've still got to do, and this is the timeline with which it will be delivered. I'm not doubting at the moment that work is not being done, but I just don't have it in front of me today. So that's the context I think we're going to hear for some of these questions, as well as some of the detail today. So that's really just where we are. Just to say, I think that we asked at our last committee meeting back in July for a good, I can't remember exactly what the words were. I'd have to go back and look at the recording if it's still available, in terms of a significant update to this committee, because we were aware of the timelines. And our next committee is November, where we'll be probably well into the delivery phase by then. So I'm going to stop at that point and maybe just invite committee members now just to raise their points. But I think it's important context there. So Christopher, I'll ask you first.
Hello. Yes. My question doesn't relate exactly to that, but I'm sure it's influenced considerably by the delivery system that we finish up with. Tim, you mentioned that you were rather disappointed by various aspects of immunisation uptake, I must say I'm really disappointed to see in children that the MMR uptake, as low as it is, still, I mean, we know it has been low, and we know the reasons for it in the background, but I thought it was coming back rather better than the figures show. And also, I'm very surprised by the relatively low uptake in adults of COVID-19 immunization these days. I wonder if any actions are being taken to try to improve these figures, and if so, what they might be.
Thank you, Christopher. I wonder, rather than asking Tim and Pam to respond to this, we might collect a few points, just because I suspect that they may well be similar, and we can just it'll give Tim and Pam time to collect their thoughts rather than responding and going back and forward. But we will most certainly answer the questions. Philip.
Yeah, thanks, Jerry. Just in terms of the options, I was wondering, you mentioned that that's due imminent there. I just wondered if Pam or Tim will be able to tell us, is that available? What likelihood is there for the to be delivered, and what timescale we're looking at for that?
Okay, I'll move on to Joanne, and then maybe I'll ask Tim and Pam to come in.
Neil was before me. Was that a deliberate, Jerry? You're on mute now.
Neil, you're first. Sorry, apologies.
It's okay. It's really very much along the lines of Councillor Burt. Tim, and I appreciate we are already going down a path of options appraisals, but I guess my thoughts were, given that childhood uptake seems to have declined a little across Scotland and more so across Highland, what work has been done? What evidence is there to work out why? Because why should then inform how we're going to turn that around. So it's an open question. What evidence is it? What has anybody spoken to parents as to why they're not taking their kids to vaccinations?
Thank you very much for that, Neil. So we'll maybe take those two main points first in terms of uptake, and I think Neil asked an excellent question. Do we understand why it is lower than we perhaps might like it to be? And then we'll ask Tim or Pam, I suspect Pam, to come back on the timelines for the options appraisal. Tim.
Yeah. Oh, do you want to take Joanne had a? Oh, shall I just answer those, or do you want to?
I'll take these points first, and then come back to Joanne and Anne.
Yeah. Okay. So first of all, if I start, yeah. I mean, I think encouraging. I think there are two elements to around uptake. One is the national trend around uptake, and the second is local issues. And there has certainly been local issues with the change to from GP delivery to board delivery, and that has been seen in other boards when there was the transition before, but there was a bit of a bounce back, which I've seen maybe a little bit, and it could well be that Highland's a little bit different. And I think there is one of the principal things I'd be most concerned about is some degree of loss of confidence in the vaccination system. And I think that's something that we need really to try and improve, but that will take a long time. But is one of the most important things. And I think that local factors are things that we're trying to correct as much as we can through things like the options appraisal, but also through a specific review where reviewing all children who are not vaccinated with the 6-in-1 vaccine, and all children with not vaccinated with MMR, and going back and looking to contact them, find reasons, and offer vaccinations. there are lots of, I mean, Neil will know about issues in terms of connecting with the vaccination data with primary care, which is an issue throughout Scotland, and that may be something that actually is a national effect. But we need a better workaround. We haven't really got a workaround other places have. So I think there's probably a collection of reasons, both national and local. And I think probably our most important thing at the moment is to make sure that we've got a better local system, because that's the things that we can that we can more easily do about. We are taking other specific. George, just moving on to adults, I suppose. COVID vaccine, I think, has been going down. The uptake's been going down nationally, and I think there's a bit of fatigue in terms of people being happy to be vaccinated. The vaccine does also have side effects, and I think we need to be honest about that, and can be painful. People can be ill for a day or so, and that does affect people, and I think that's one of the reasons why people are less willing to have renewed COVID vaccine. A lot of the efforts are national in terms of trying to promote the importance of vaccine. We're also doing local work. I mean, just as one example, I'm going to the Highland Self-Management Forum tomorrow to promote vaccination and to answer. I've got lots of probably more probing questions than I'm getting today. I'm going to get at the Highlands. I've got advance notice of some, so I think I'll get some very probing questions tomorrow. So we're trying to increase the vaccination uptake. I think there's also something around the service delivery and improving that. For most of the time of COVID vaccination, we had care home vaccination rates much higher than the Scottish average, and getting on towards 100%. Sometimes it's a little bit slow, but we're generally pretty high rates. But the last round we were actually below the Scottish average, and we were going down a bit. And I mean, clearly, care home residents can refuse to be vaccinated, but the number who'll do that will be fairly small. So really, it's a group of people who should have very high vaccination rates, and we shouldn't be lower than Scotland for any vaccination rates. Really, certainly not for care homes. So I think there's a combination of factors at play, and there is more work looking into the why. In terms, I mean, we're asking people to do more surveys. We've got some qualitative work planned to look at why parents aren't bringing their children for vaccination. I think that there is a cohort. I was just looking this morning at the I think it's the 6-in-1 data, and I think we had something like 59 refusals. So there's a group of people who actually make a clear decision. We might disagree with that and really want them to have their children vaccinated, but there will be a smallish percent, 3-4%, maybe 2-4% of the population who will continue to refuse. But with others, it's probably mostly around opportunity and making sure it's easy for people. And I think that's one of the things that we really need to concentrate on. In terms of the options appraisal, I mean, others may well be able to comment better than me. I think it's worth saying, just to pick up on Jerry's point earlier, that, and it is a little bit of a special pleading, but earlier on in the year, we were more looking at reconfiguring the delivery of the service to be a more locality-based model, and one where there wasn't less of a specialist vaccination service and more of a general vaccination service. What we've moved to is an options appraisal about looking at the delivery of different options, particularly including getting back to primary care delivery. And so we talk about options appraisal and different options for delivery. We're actually talking about two different things. And there are several reasons why we're looking at the different things. And one of those is certainly our perception that there is a movement of possibility within Scottish Government where it was very difficult to have a mixed model with primary care delivery, and the perception is that it will be easier now. But we're still only at one stage in the process. So I think that explains that if it hadn't been for that, then we might actually oddly have been more down the model. Hopefully what we're going to is a long-standing, more sustainable, better model in the longer term than we would have had. That's what I'm hoping. In terms of the time scale, so the actual options appraisal work and the short life working group is largely finished. There's still some further work to do with a paper going to the executive directors group on next Monday, when it's due. Then the proposal from NHS Highland will go to, I think it's probably from the HSCP and from NHS Highland, will go to the GPC committee, and they will pass judgment on what is possible in terms of delivery, what may be possible delivery in terms of contractual arrangements and things like that, and then we will move on to an implementation phase. So it will take longer than it would have done with the original plan of having a more of a locality based service, but I hope that we'll come out with a better service, a better, more sustainable, longer term service that will give higher uptake rates and a better quality of service.
Thank you very much, Tim. Pam, anything you want to add to what Tim just updated us on?
Yes, so we do need to go through formal processes. We've done a lot of work just up until we had the Public Health Scotland review in terms of an input model. So we know our local delivery, we know our local areas, we know our local workforce in terms of looking at that sort of district model and that local based population. There's still elements of choice, around how people engage with vaccinations. You'll be aware of yourselves of the kind of national campaign that's in the media. So this, although our uptake rates in some ways are a bit lower in some categories, there has been a national reduction, and particularly even our frontline workforce, persuading the workforce to be vaccinated across the campaigns is a particular challenge as well. In terms of the data, a couple of the issues we were talking about in the improvement group this morning was that when new people move into the area, we don't have their vaccination status, particularly for newborns and very young infants. So we need to make contact with them, and we need to make sure and clarify their vaccination status. And sometimes, in terms of the time that we pull down the data, we might miss a few people. So I hope that just shows that we're looking at all of the aspects and the reasons and what we can do to improve. I think one of the points, just going back to Neil's question, what is the evidence? Sometimes we just don't know why people don't want to engage with vaccinations. We have done direct contact with people, and we followed them up again when they've said no. We've tried to bring them into campaigns, and whether it's personal reasons, and it's not this. These are the ones that are not about accessibility. They're exercising personal choice not to engage with vaccine programmes, and it would be good if we could summarise some of that data and outputs and bring it back to the committee as well, just to firm up the outcomes to that question. Thank you.
Thank you, Pam. I'll bring in Joanne and Anne.
Hey, thanks, Jerry. Tim, I think you've covered most. I think I had concerns over the confidence of people with long-term health conditions using the uptake on the COVID and flu vaccine, and if they're not going to do that, then their impact on their well-being coming into the winter months, because then they don't have the confidence to go out and mix and socialise and be socially engaged in community. So it has a much kind of wider impact from what I'm seeing within communities that I work with my other hat on. We've had people who don't want to get the vaccines together. They don't want the COVID and flu at the same point in time. We've got a number of people saying about the side effects, which you touched on. So that's putting people off actually taking up the vaccine. And I don't know if you can do any kind of comms around to help kind of improve that, because I think people aren't taking it up because they're hearing a lot of it as maybe word of mouth. They know somebody who's had really bad side effects and then they're just not going. A lot of people are very compromised, so it's not really a very good picture out in some of the communities that I'm engaged with. They're not digitally enabled, so access to appointments, or they're not reading papers, so when they're told to kind of keep an eye out, then they just lose interest and they don't bother if they can't get an appointment near them. I've heard that story quite a few times. There are patients with long COVID who aren't getting offered the vaccine. I don't know whether they're not on the list. I think they're not, but maybe a bit of confirmation over that, because obviously they have lowered immune systems anyway with having long COVID. And I guess for you were saying about the timeframes, that was one of the ones I had, but you'd gone on to talk about the survey for the vaccines to gain input from the community. Just a query on equity of that, Tim, because if it's on text and I know it's online on Facebook, there's a lot of people who don't have mobiles and aren't digitally enabled. So and they're probably the most vulnerable in terms of maybe not being able to reach. So how are we actually going to reach out to those people in communities? And finally, just one around access to the antibody therapies. Is that still available within NHS Highland if people contract COVID? And is it through GP services? Do they still get a letter? Does it come out from you, or does it come out nationally? Thank you.
Thank you, Joanne. Quite a few questions in there. I'm going to maybe let Tim pick them up now rather than add anything to them at the moment. If you want to just respond, Tim.
Thanks. Yeah. I mean, Joanne's actually picked up a few of the questions, which as a primer for tomorrow, which I'm going to be asked. In terms of getting both, one of them is in terms of getting both. Well, ways of encouraging people to get vaccinated. I think we ought to try and be flexible to be to help people to be to maximise the opportunity for vaccination. I would hope that if people really don't want to have two vaccinations at the same time, if they've got good reason for that, which they may very well have, then we will be flexible and allow that. And I need to check that out. That's a specific question I've got. I need to check that out with the service. Clearly, it's not desirable for the service because but often at places like Eastgate, actually, there is a fair amount of capacity around. Certainly, every time I've been to Eastgate, there's been a lot of capacity. So that may not be too much of an issue. And we certainly want to encourage, and we do what we can to encourage people. I think it is tricky. We're not particularly outliers. We're a little bit lower, we've fallen off a little bit, but we're not significantly outliers from the national picture in terms of who's getting vaccinated. So and the numbers for adults and COVID and flu. So I think that there must be some national elements and some sort of secular trend in that, but we will try to put more communications out. In terms of the survey, I'm not sure what else is being done. Claire may know a little bit more than me, but we can come back. People who are immunosuppressed. I mean, it's the list of those immunosuppressed is taken nationally, and it's taken through GP records. So I think there are criteria for who's immunosuppressed to the level of getting COVID vaccination at a younger age or at any age. But it may well be that people with long COVID don't get that because it's not deemed that they would have that particular level of immunosuppression. Antibody therapy is another question I'm going to be asked. So I have the categorical answer to that. So I've just got that up. Patients eligible for antiviral medication are usually informed by their GP or specialist teams. They can get lateral flow tests from the NHS Inform website, and then there are board contact numbers available, and so the treatment is still available and it's managed through the Flow Navigation Centre. I won't go. I've got more details on that, but I won't. I won't go on to any. So I think probably like everywhere, the service isn't ideal. I'm not responsible for that service, but it is available.
Thank you very much indeed, Tim. Anne, your hand has went down. Do you still have some questions you wanted to pick up, or have we picked them all up as we've progressed?
I think, yeah, I think I was just conscious of time, Jerry.
Yep. Okay.
To move on.
Thank you very much. I know we spent a little bit of time on that, but I thought we needed to spend a little bit of time on that. And I think the question for me is, and I'm talking in relation to this committee, is what next in relation to this. I think what I'm hearing from Tim and Pam is we're unlikely to be implementing anything. Not that we'll be doing nothing. I don't want it to sound like that. We'll be unlikely to be implementing anything arising from the option appraisal prior to the next committee. Just because of time. By the time, I think, as we said, by the time it goes through EDG, various routes, and eventually we get feedback from Scottish Government. So I think that gives us time to get something back to the next committee. I'll maybe have a discussion with Pam offline in terms of what that would be, but I think what I would certainly be expecting it to be would be a detailed, this is the actions, this is where we are, these are the ones that are complete, this is and so forth. And maybe by that time, if we've had the feedback from Scottish Government, we'll actually know what the answer is. I'm quite clear it's not for this committee to second guess what the result of the options appraisal is. The result of the options appraisal is what the options appraisal is, but it is for the role of this committee to have and provide assurance to the board in terms of the process that's been followed. It's not for us to second guess the answer or the recommendation that is going to EDG. That's what it will be in terms of that, but we most certainly have a role there in terms of the process, and not just in terms of the options appraisal, because what I'm guessing, although I don't know, which is part of the problem, is I should imagine for a significant piece of our autumn-winter campaign, people will be accessing the system in exactly the same way as they accessed last year, and it's getting that assurance that those improvement issues in relation to what we were doing this time last year have actually been enacted, so we can mitigate against some of that. So I'll have a conversation with Pam in terms of what we bring to the next committee, but I think I'd be looking for a substantial report to the next committee in terms of exactly where we are, and being quite honest about its names, dates and places level of report.
Yes.
Yeah. Okay.
Yeah.
So we're been asked on behalf of Pam and Tim to accept limited assurance in terms of where we are on the progress we're making towards the vaccination improvement programme. Are we content to do so? Yep, we are. Thank you very much indeed. Thank you to Pam and Tim for that. We're moving on to IPQR now, and I thought I saw Lorraine on the screen there. Yes, I did indeed. Lorraine joined us. Lorraine, you went with us at the start, so we've had what I've suggested right at the start. We had the internal audit report on delayed discharges, and Pam's Chief Officer report contains a lot of detail on the requirements of Scottish Government in relation to the reduction in delayed discharges. So I'm suggesting as we go through the IPQR, particularly in relation to the delayed discharges, we pick up those issues there as well. And I'll maybe ask Pam to pause on delayed discharges and take us through all of those aspects so we don't repeat a conversation. We have it once. But I'll maybe ask your good self, Lorraine, to take us through the IPQR for the Health and Social Care Partnership. Thank you.
Thank you, Jerry, and good afternoon. we've had, as you'll see, we've reflected in the IPQR some of the wider metrics that need to be included as part of Together We Care. So there has been some additional metrics added this month that I discussed with Jerry and Pam previously to give that more rounded approach to the IPQR. We've also changed the narrative section in each of the areas to reflect the key agreements as part of the annual delivery plan. So these are the things that were signed off, and on discussion with Pam, all of the areas have provided the reasons for the current performance, the plan and mitigation, and the expected impact. Now, I would hope as we progress, like you've just discussed with vaccinations, we could start to move to a more numerical trajectory for each of these areas to be able to, I guess, assess ourselves on that performance and where we expect to get to at the end of any particular period of time. What we've also done this month is on discussion, really looking at data through different lenses. So the IPQR is meant to be that integrated performance and quality report. So how do we look at performance and quality, which are inextricably linked through different lenses? So you'll see at the beginning that we've described which of the governance committees look at particular areas and where we've got that included in the Health and Social Care Partnership one today. So if I turn to each of the areas, we've got the vaccines, which you've just discussed. We've also included children's vaccines, given the report by Tim and Pam. We've expanded and given some data on adult protection and community hospital length of stay. We've also got community mental health waiting lists within there, and chronic pain, which is a responsibility of the Health and Social Care Partnership. And we've included palliative and end-of-life care. I'm obviously aware of time, Jerry, and you've had the report for a few days, not quite as quickly as I would like, so I just apologise into the committee for that, but happy to pick up on any data quality issues, and I'm sure colleagues are happy to answer questions on the performance and or the narrative. Thanks, Jerry.
Thank you very much, Lorraine. I'll maybe ask you a question first, and then Pam, just to give you a bit of advance warning, I'll maybe ask you to take us through the delayed discharge, current performance, government targets, internal audit report, bring that to, because it may well be that will circumvent some of the questions which colleagues maybe have been preparing to ask. I just wanted to pick up and this is for Pam or Lorraine, what might be, have we got a timeline potential for moving towards more robust numerical based trajectories and getting that on there? Because I think that's, and I know we've had this conversation before, Lorraine, in terms of it's where do we expect to be? Because I continually make the point of, if we're doing as well as we can be given all the other circumstances, let's stop flogging a dead horse for improvement without recognising that actually we just can't get better if we're actually at that maximum. So when do you think we might actually have those trajectories in place which will give us an idea of what our optimal performance could be based on today's set of circumstances and the improvements that we have in the system?
So I think you'll have heard me talk about potentially an FRP for those that attend, about integrated service planning and really understanding what capacity, or DCAQ, sorry, for that's demand, capacity, activity and Q. So what have we got within the services and what can we deliver? So for some of the community services at the moment, like podiatry, more the AHP services, they're mapping that out through ISP, which would start to get us an understanding about how much we can deliver within the resources that we've got. That needs to continue. And once we complete that exercise within the Health and Social Care Partnership, that will give us the same level of trajectories as we've now currently got within the planned care. But that is a quite a huge undertaking to do each of the services. So that will be an ongoing process over the coming year. But I hope that with the data that we've got now and being broken down into individual areas, Pam and I discussed, really looking at how we can set that targets and really understand what the data needs to go around that. So definitely a work in progress, Jerry.
Thank you very much. Lorraine, Pam, anything you want to add to that? Are you content with what Lorraine's updated us with? Oh, you're on mute, Pam.
It's okay. I've just had a problem with my
Teams, and I've had to go on. Sorry. Can't get into.
Oh, we're in a feedback loop, I think.
Yeah.
Okay,
Right, can you hear me?
Oh, yes. That's fine. Thank you very much, Pam. That's fine. It was just whether he'd anything to add to Lorraine's comments, or you were content with what Lorraine has updated us on.
Yes, can you hear me? Because I can't see you on the screen, but I've kind of.
Oh yes, we can hear you absolutely fine, Pam.
Yeah. So I'll take you through the 90-day programme. I would say that as part of the governance of that programme, we've re-looked at our sort of governance and accountability structure, and we've stood up a system capacity group. And within that group as well, we'll understand much more about the capacity that we have across the system. In terms of the beds we have available, the real-time information, how that helps us with trajectories. There's been, a look again at the delayed discharge data to make sure that we've got people at the right stage of their hospital stay on the list in the right context. So sometimes they've gone on at the beginning, but their information hasn't been updated. So there's been a lot of work done across the acute sector and with the district management teams to improve that position. So that gives us more internal information to add on to the aspects that Lorraine was outlining, and that's very much within our governance and accountability structure for urgent and unscheduled care. So within my report, my Chief Officer report this month had again updated more around the collaborative response and assurance group, which has been meeting weekly and is maturing a bit. And as part of that process, we have provided assurance back directly to the Cabinet Secretary, directly to the Permanent Secretary, who visited NHS Highland, and we were able to present a refocused structure for the delivery of urgent and unscheduled care in this specific 90-day programme that we've drawn up. So it's been seen by the Permanent Secretary for Scottish Government, who is effectively John Swinney's highest civil servant. He came with the Director of Adult Social Care from the Scottish Government. And also we've had quite a lot of meetings with Miss Todd in her capacity as Minister for Social Care, Mental Health, Wellbeing and Sport, and she's chaired the CRAG meeting on behalf of the Cabinet Secretary himself. And we've also had bespoke meetings with COSLA representatives. We've had some support around self-directed support and adults with incapacity legislation and learning from other systems. So that's been the kind of big strategic piece. But within our organisation then, we have developed and settled on a 90-day plan on a page, a 90-day improvement programme, and that's what I've outlined in my Chief Officer's report. And one thing I would say is that there's not an annual winter plan coming this year. What we need to do is agree that we've got a robust improvement plan, and that we can stand up elements of those plans to improve flow. And that goes back to us having, improving our data and understanding our system a bit better in terms of how it's performing, where our capacity is, how we manage surge, how we anticipate winter pressures and any of the increasing demands. We do plan to reduce our delayed discharges ahead of the winter period. So part of this 90-day programme is to look at increasing capacity across our community and existing statutory run care home services, and we're working in partnership with the Independent Care Service around what that would look like, around what it would take to open up and make sure that we're using all of the capacity that we've got. There's a number of risks around that in terms of we're going to have to largely staff with agency staffing to create capacity. Plus, we've got our forthcoming Health and Care Staffing Act, which we need to be mindful of as well. And we've also got other parallel improvement programmes in place. However, we've established that we can increase some capacity for people who are delayed in hospital. There's also people waiting at home for care home admission. And there's also a number of people waiting for care at home. So we need to address that capacity as well and really be clear about progressing our longer term strategic plan to enable people to live at home as independently or as supported as possible for as long as possible. So we should be focusing on developing our care at home capacity as well as looking at care home need. So within our 90-day action plan, our key responses around adult social care audit, particularly around standard operating procedures, making sure that staff actually understand what it is we're trying to achieve in terms of the plan, understanding the flow, where people are contributing as part of the process. And one of the key elements that would support Lorraine and her team is the consistent input of data and keeping data up to date so that we can manage where people currently are in the process. So our 90-day improvement plan has 4 strategic areas in terms of response, so responding quickly to support people so that when there is increased demand for attendance at hospital, for emergency department, etc., that we're able to turn them around quickly and get them back home, and that we don't end up with people in hospital who experience delays and poorer outcomes. Our rapid element, a rapid area is around rapid discharge. So when people do have to be admitted, that they have a planned date of discharge, that we are able to work across health and community and achieve some of our outcomes. And a lot of that has to be supported with standard work and making sure, as we learn from the audit, that staff are really clear about what is the app that we're trying to use, how do people engage with it. We've currently got about 700 staff inputting into the app. So what does that mean in terms of data and where people are in the process and how we manage all of that in a standard way, in a standard work way, and also where can we put in the technology-enabled care solutions to enable people to go home and be managed at home. And a key part of the rapid response is our pre-noon discharge plan, which we're incrementally improving on. We need to reduce our occupancy and develop new systems and revisit systems that we've had in place. So one of the national discussions we were having was around the hospital at home funding, how that was given to us, that we stood up services, had them in place, and then the funding came to an end and we had to go into a new application process. So good engagement nationally just around what that's like operationally, and the stopping and starting of things doesn't help flow, in terms of managing that virtual bed capacity or putting people home early so that they can access same-day diagnostics locally, for example, if we've got a hospital at home service or peripatetic staff in the community. So an advantage of having that national interface is the ability to give feedback around some of the national inputs and ways of working that affect us operationally and our ability to deliver timely and move people through the process. And in terms of a redirect. Excuse me. Sorry. Sorry. I'll have to stop there. Sorry.
Pam, you get yourself a drink and we'll move on with questions about other aspects of the IPQR. So I'll maybe just I'll let Pam gets herself a drink and clears her throat. Well, I'll maybe just throw the balance of the IPQR open to questions by committee members for Lorraine and or hopefully not Pam, given she's still coughing away. In terms of probably in terms of the content, in terms of maybe how we further like to see it, the layout and so forth, and the content developed. Anyone? Nope, I'm no. Muriel, thank you.
Sorry, I had camera problems. I was going to say the 90-day plan. We all it's been explained. How are we going to get feedback of how that is going? And I think that is a concern when there is something as strict as a 90-day plan put in place. The other thing, are we monitoring? I presume, I could be wrong, that we're monitoring the reduction in out of areas placements that we need to, because we're at capacity, but are we monitoring how many clients we're having to put into Murray or whatever? Does that come into it as well, and the costs attributed to that?
Thank you, Muriel. Pam, are you able to pick those questions up, or will we capture them outside of the meeting?
I'm happy to come in, Jerry, if it
thank
helps.
you, Lorraine.
I think
that'd be helpful.
Because I obviously worked with Pam and Catherine to develop the plan. So the 90-day plan, I think Pam was getting to the redirect section. So just about how we use, our services and how do we, I guess, support that redirection to appropriate services where we can. So that was the final section of the plan that Pam was away to cover. For each of the particular elements, that the 4 themes, they're really focusing on what you would have seen last winter. Or the winter before, perhaps, actually, because I wasn't around last winter, the winter before, and really breaking down into each of the elements what we need to do. Some of them are basic elements, some of them are, about capacity, some of them about process. But for each of those, we've got a KPI or a measurement of success. And also a similar process with vaccinations. How are we going to measure if that has been achieved or not? And what is the proper project management of monitoring to get towards that 90 days? It's 90 days because we don't have long until winter sets in, as everybody will have noticed with the dark nights. So we really want to make a concerted effort to create that capacity. So there is a more detailed report could come, Muriel, to complement that overall plan.
Thank you, Lorraine. That's exactly what I was thinking there. It would be useful to have something that focuses on the 90-day plan, just particularly because of the attention which it will be getting from Scottish Government. And I think the need for it to have gone through a governance route in terms of our delivery against that plan, rather than just incorporating it into the IPQR, which I know you would be able to do as well, but probably just pulling it out of that would be helpful, and we'll be advised of when the appropriate timeline for that was going to be, because I think the 90 days are August, September, October notionally. That's the broad content of the 90 days. So probably in time for our next committee meeting in terms of where we are and where we expect to be. So I've got Joanne and then Anne.
Thanks, Jerry. Lorraine, just coming back to you on this, guess the design of it. For me, visually, it's quite difficult to read because it's a lot of colours and kind of sectioned off. It took me a couple of attempts to go through it to kind of pick out the information I wanted. Also, some of your graphs and the content seem to be copy and pasted in, and then when you go to enlarge them, you can't actually read them. So graphically, I can't actually access all of it to read to see what it says. Just a bit of feedback on that. And I think you've spoken about trajectories, but I felt throughout reading it that there was no kind of dates and timelines in for any of the plans and mitigations, which made it a bit kind of, it was hard to get a picture on where it was at. And then some of them had trends and some of them didn't. So I struggled a wee bit with the new format, but that's just my opinion.
Thanks, Joanne. I think that for them all, I mean, Pam's off the call, but we discussed about, I guess, setting that trends and trajectories and really looking, some of it's new data, some of it's only available once per year. And what we were trying to do was use the discovery data so that it'd be on the appropriate timeline for benchmarking as well. I think I've acknowledged that, you know, I think there'll always be a work in progress. I think Anne said to me at board, you know, it's always evolving and changing. But I think that for each of the sections, I would agree that that expected impact and what it's going to do needs to be far clearer, and where we're going to get to. But that needs quite a lot of work in collaboration with the services. Michelle's obviously new in post, but how do we really understand what we're doing as a system, and make sure that we are monitoring our performance based on that? Sorry about the colours, and we're trying to align it to Together We Care, so the different strategic themes were, which you'll see at board within the FRP CGC as well. So, but noted, Joanne.
Thank you, Lorraine. Thank you. And I know the feedback is taken in the spirit it's given. So that's always. Anne, I saw your hand up and then went down again. Are you okay?
Sorry, I was simply going to ask when are the 90 days going to come to an end? That I was wanting to know what the specific timescales were and how that would relate to our next committee meeting.
Yeah, I'm not sure there was an actual start date, but I think it's broadly August through October is the 90 days. So hopefully it fits in to a timeline for the next committee cycle. But I'll pick that up with Pam. Sort of.
Jerry, you're correct. It was presented to the Permanent Secretary around the 19th of July, and there was agreement that it would commence August, September, October to align with that. The winter checklist, in terms of the winter plan, will be out in the next 2 or 3 weeks. But I think from seeing a draft at Directors of Planning, we have most elements already included within our 90-day plan, fortuitously. So I guess the focus needs to be about delivery of that plan, and making sure that we've got the right mechanisms in place to monitor that.
Thank you very much, Lorraine. I'm not seeing any further hands, and so I think we'll bring the IPQR item to an end, and we've been asked to accept limited assurance on that. And I'm sure if there's any other comments, observations anyone would make, we could pass them directly to Lorraine. So are we happy to accept the limited assurance? Seeing thumbs up. I should say content. We're never happy to take limited assurance. Content. Thank you very much indeed. Item 3.5 is the two internal audit reports. These, I think, as Pam has stated in her cover paper, these have been considered at the audit committee in the full context of the full report and discussion with the internal auditors. I thought it was important they came here so we understood the actions that were ongoing out of there, and there's going to be a further update provided to the September audit committee. So again, I will liaise with Pam in terms of actually when evidence is actually presented to the internal auditors for completion of the internal audits, what we can bring to this committee that actually makes sense. But I wasn't proposing any more discussion on those of that one item, those internal audit reports. And are we happy to accept the moderate assurance that there is work progressing on both of those? Oh, I can hear someone. No, I saw some thumbs up, so we'll take moderate assurance. And I think just in time, Pam is back with us. We've got item 3.6 is the Health and Social Care Partnership Annual Report, which is a 50-odd page document. Now that report, this is required to be prepared by all partnerships across Scotland every year. Again, we are slightly it's predominantly prepared by IJBs. Again, we've got our lead agency arrangements. So it's with us today in draft format. I'm not proposing to go through the 56 pages or whatever it is today. It's really there for you to read and digest. And maybe, I think, Pam, maybe just send any comments to your good self. And if anybody's got any questions or any observations they would propose, they would like to see reflected in that. And I think the plan is that it goes to the next meeting of the GMC prior to submission to government. Would that be correct, Pam?
Yes, it'll need to go to EDG. One of the issues is in terms of sequencing and committee meetings, then the National Health and the Health and Social Care, Health and Wellbeing Outcomes, I should say, are not officially published, but they are a retrospective look. So this report is a retrospective look on our performance, but we want to try and be really outcome focused against that data. Yeah. So it will come back to committee in a more robust format, but we thought it would be helpful if people had a chance to read it and, you know, from the members of the committee to give any further guidance or areas where you think we should be demonstrating our outcomes. I'd be happy to receive that type of feedback. That would be good. Thank you.
Thank you very much indeed, Pam. And that brings us on to your own Chief Officer report, and I know we picked up a considerable amount of it in terms of that discussion about delayed discharges, but if you'd like to take us through other key points.
Yes, so in terms of the things I wanted just to bring to attention is that you know, there's been an ongoing focus on our service redesign. So we've had a further meeting of the Sir Lewis Ritchie steering group at the end of August there with on Sky. So that's going really well, and we are looking at how we move some of that service redesign into the district planning group. And on that aspect, you know, the district planning groups have been stood up in all of our districts. So using our planning for people guidance and engaging further about the service delivery and models of care that we've outlined in our joint strategic plan. That's part of our implementation. So we may want to have a more focused look, and that there has been more national communication around engaging with people strategy and what we're trying to achieve around that. And certainly at the Sir Lewis Ritchie meeting, we had you know, the local community there with NHS 24, with Scottish Ambulance service there with local councillors. So, you know, we need to move that into the district planning group mechanism and not run different groups in different areas to achieve the same outputs and make sure that we're looking across all of our services. National focus on discharge without delay. I was just going through that when I had my coughing fit, so apologies. Just in terms of the redirecting piece that I was talking to, you know, our community urgent care response is really important in terms of making sure that we manage people in the right place. So making sure that we can turn you know, urgent care into scheduled care, and making sure that people know where to contact to get the right service. And there's also wider pieces of work as well to pick up in terms of our frailty strategy that Dr. Copeland's leading on as part of our primary care strategy, etc. So there's very, very big pieces of work. I mentioned the winter plan. In terms of the Joint Monitoring Committee, we've held a development session with them. The next meeting of the committee is on the 25th of September. So we're taking a number of reports through there. Enhanced services are progressing. 9 new contracts for enhanced services are being developed, and they're currently in an offer position. So I can't give more of an update than to say that we've engaged collaboratively with Highland LMC to agree those enhanced service contracts. So that's been a significant piece of work. We had a really good in-person event with the care home sector. You know, it was called Care Homes Making a Difference Listening and Learning Collaboration event. So that was chaired by Louise Bussell, our board nurse director. Really good engagement from across the sector, really good attendance despite all of our challenges in terms of delivery. We were able to come together in person, a lot of us reflecting that we hadn't been able to do that since the COVID-19 outbreak. So that was a really, really good event, and a really good engagement and a good understanding of where some of our issues are and where we can work collaboratively on our challenges, and create more capacity. So that was really good in terms of improving our relationship. So there will be a report from the event. We're just pulling that together. Gillian Grant's leading on that, supporting Louise to get that into the right shape. So we'll bring that back to committee, but it was just a great event. And again, in terms of the National Care Service, we had a development session with the NHS board. I attached a fact sheet to the to my chief officer report, because it's quite good just to have the facts to be able to read and digest that yourself, and then participate in the different fora that we're going to have going forward in terms of taking forward the National Care Service implementation as it's guided through Scottish Parliament. So I think I will just stop there. Thank you.
Thank you very much, Pam. And I see at the bottom of your report there, in terms of, I think we will have a think about committee-wise what we do in relation to the National Care Service, but it's probably going to be when something becomes a bit more fixed, then we can actually have a discussion about something, because at the moment we've got proposed stage 2 amendments, and as it progresses through Parliament we'll understand that, but be aware, committee members, that we are cited on it, and we will have a discussion at the committee to feed into the board and allow members to feed into various routes as well. So thank you very much for that, Pam.
Thank you.
Final item on the agenda, we've got committee meeting dates. Stephen is tremendously organised, and we've got dates right through to the 3rd of March 2027 there. We thought it was nice. We've standardised on the first Wednesday. Is it the first Wednesday of the month, Stephen? Yes, first Wednesday. Yeah, alternate. Yeah, just to get people, allow things to get into the diary. But we will not wish our lives away by looking at those, and we will factor into that development sessions as well. Any other competent business that anyone wishes to raise? Nope. So I will bring the meeting to a close, and I will see you all again in this forum. I will see lots of you elsewhere. I will see you all lots at this meeting on Wednesday, 6th of November 2024. Thank you very much indeed, and enjoy what's left of your afternoon. Thank you very much.
Thank you.
Bye.